Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit Podcast. And we are back. Welcome to the Med Edit Podcast. I'm your host, Dr. Jessica Gray, here with my co-host, Dr. Cari Sorrell, for another highly educational episode.
First up today, we're tackling diabetes. Now, Jess, I know you know this, but for our listeners, did you know that 1 in 3 people in the United States are pre-diabetic? That's 33%. That number should concern you a little because that's a lot, but don't fear. We're here to talk about what it means to be pre-diabetic or diabetic, what you can do to take charge of your health and reverse this course.
And then in the second half of our show today, we're bringing back the sports hype segments.
Yay.
This is where medicine and sports meet. We dive into a very hot topic, concussions and CTE.
You know, during like NFL college football season, we love to throw in a little sports education. It just feels appropriate for the season.
Absolutely. Sit back, relax, put on those headphones or turn up the volume in your car. And we're just here to edit out the noise and bring you some medical education without misinformation.
Many people are not aware of their risk for diabetes. More than 38 million Americans have diabetes, which is 1 in 10 people. About maybe 90 to 95% of them have type 2 diabetes. In this episode, we're mostly going to focus on type 2 diabetes because of that, which is different than the autoimmune type 1 diabetes that often presents in childhood or adolescence. Type 2 diabetes most often develops in people 45 years or older, but more and more children, teens, and young adults are also developing it. Type 2 diabetes is becoming more common and more prevalent, contributing to increase in many life-threatening conditions such as heart disease or cardiovascular disease or kidney disease. And of course, for me, liver disease as well. This is why this discussion is crucial to public health. You know somebody who has diabetes if you yourself don't have diabetes. The biggest thing to focus on is that most cases of type 2 diabetes can be prevented. By addressing risk factors and lifestyle, you can treat and sometimes reverse type 2 diabetes. Treatment for type 2 diabetes has also dramatically changed over the last 10 years, and we're going to break it all down.
In my practice as a family medicine physician, I diagnose and treat diabetes all day, every day. In fact, probably this day and age, it's about 75% of my patients I'm seeing in clinic have diabetes or are pre-diabetic, which is shocking. When I first decided to start in family medicine, I had absolutely no idea the amount of diabetic management I'd actually do. But over the past 10 years, the number of patients that I've seen with diabetes managed, diagnosed has just absolutely skyrocketed. Thankfully, I also get to help these patients take back control of their health by making necessary changes to prevent or even reverse type 2 diabetes, which is really exciting even for your doctor to be able to help you achieve those milestones.
Absolutely. And of course, with the sheer number of people we're seeing, unfortunately, you can't refer every single one of those patients to an endocrinologist to manage their diabetes, right?
Oh,
So
no.
as their primary care physician, you have to be well versed in these things, or even many specialties because of the large number of people it applies to, where they're seeing, their GI doctor and for liver disease. And, you have to be able to understand the new medications that are out, or their heart doctor for their heart disease, or their kidney doctor. So it's not even just a primary care physician problem anymore. We're all seeing it and have to be well versed in diabetes.
Absolutely. All of us medical providers do have to have some knowledge about diabetes and be comfortable with it. And even our endocrinologists here, we love them to death. We've had one of our endocrinologists we love here on the podcast. So even when we've had endocrinologists here on our podcast, they've talked about some really advanced endocrinology needs. And it is one of those things that they manage diabetes, but a lot of them don't have time to manage the bread and butter diabetic care. And that's what all of us as primary care providers are really focused on trying to help, not only our patients be successful with, but make sure that we as providers know what we're talking about and stay up to date with that information.
Absolutely. Absolutely. So let's say you have a patient coming in and they're concerned about their risk for diabetes. Maybe they listen to our podcast or hopefully, or maybe they talk to a friend or another doctor. Let's just call them Sally Mae. Where do you start your discussion with these patients?
So I love this because I could probably do this in my sleep nowadays. But yeah, so let's talk about Sally Mae. Let's say she comes in and we're going to start talking about maybe her risk factors for diabetes first. So risk factors for type 2 diabetes include several things, and a lot of things people don't actually think about. Number one would be having pre-diabetes. Well, duh, that should make perfect sense. If you have pre-diabetes, which means elevated blood sugars, you probably are at risk for developing diabetes. Got it. But being overweight, being 45 years of age or older, having a parent, brother, or sister with diabetes. So, a first degree relative increases your risk of having diabetes by 5 to 10 times higher than somebody without having a relative with diabetes. If you're physically active less than 3 times per week, and that doesn't mean, walking the dog casually, that means actually going out for some aerobic exercise, getting that heart rate up and sustained. If you're not doing that for at least 30, 45 minutes, maybe 3 times a week, you are at risk for diabetes. Anyone who's ever had gestational diabetes, so meaning had diabetes during pregnancy. So 25% of people who have had gestational diabetes will develop diabetes, type 2 diabetes in their lifetime. So that's 1 in 4 people with gestational diabetes will develop diabetes later. You're also at higher risk if you've had a baby born at greater than 9 pounds. There's some other additional risk factors that include things related to race and ethnicity. So, if you're African American, Hispanic, or Latino, if you are American Indian, some Pacific Islander people, and Asian American people are also at higher risk. And then, of course, this is one for Cari, being a gastroenterologist. If you have non alcoholic fatty liver disease, that also puts you at risk for diabetes. So, there's several things that we would first start stratifying. Do you have any of these risk factors?
Yeah, and it's become, such a of its own issue even with the liver hepatology world. They've kind of started changing the nomenclature on that.
Hmm.
So, really the kind of non-alcoholic fatty liver disease, which really felt like kind of a catch-all for anything that wasn't alcohol, is now switching over to, well, the acronym for that is MASH instead of NASH now. So, just FYI. And it's
NASH.
a metabolic dysfunction associated liver disease. So really,
Oh,
kind of encompassing all of the like obesity, diabetes, all of those risk factors that we're seeing. So like I said, it's really becoming its own beast.
and that's one of those things that, we'll touch on in a minute too, but it's becoming more and more prevalent, people having type 2 diabetes, that we're even having to change the nomenclature and the wording we
Mhm.
use in other specialties to match the incidence of obesity, that sedentary lifestyle, all of those things that are actually increasing the risk for having diabetes down the line.
Absolutely. It's no wonder type 2 diabetes is so prevalent with all those risk factors. But what causes your body to develop it?
It all comes back to insulin. Insulin is a hormone made by your pancreas. It acts like a key to let the sugar that's circulating around in your bloodstream get inside of the cells where it can actually be broken down and used for energy. We need sugar in our body to function. You have to have some amount of it. Those cells need to utilize it, but it has to be brought in the door using that key, which is the insulin, to let it into the cells to be used. If you have type 2 diabetes, the cells do not respond normally to that insulin to open that door. They just ignore it. This is called insulin resistance. You can also have defective insulin secretion, so you're not producing enough as well by the pancreas, which is largely a result of some genetic influences and the fact that there you have to program those pancreatic cells to actually do what they're supposed to do.
Mhm.
And a lot of that takes place before you're actually even born. So there's two things that factor into type 2 diabetes and what cause it, but a lot of people will often talk about that insulin resistance. When insulin resistance and impaired insulin secretion is occurring, the pancreas responds by trying to actually just make more insulin to get the cells to respond. I think of it again, that door and key analogy, and they're just sitting there saying, knocking on that door, open up, so you can open that door and allow those cells to take that sugar inside and utilize it correctly. And those cells are just ignoring it, keeping that door shut, doing something else. So over the time, your pancreas just can't keep up. It's trying to produce the insulin. It's trying to get those cells to respond. Your blood sugar ends up rising. The large amounts of sugar circulating throughout the bloodstream just start causing damage to other organs.
Okay. Right. Wow. It's such a fine balance and quite the finesse system that our body has to take care of sugar. So let's go back to our patient in your clinic. Okay, Miss Sally Mae that we talked about. She has some risk factors you mentioned. It sounds like she's overweight. She's in her 30s. She does have a father with diabetes, and she had gestational hypertension. She's also been complaining of some symptoms such as fatigue, increased frequency of urination, some increased thirst, and cravings for food. So, what's going to be Miss Sally Mae's next step?
So, in her history, you were talking about there are a couple of risk factors there. And so, we want to break that down. So, yes, being overweight is a risk factor. She's in her 30s, and we said 45 and older were those are higher risk. But let's not forget that we keep seeing these numbers decrease over time. And so, we're
Hmm.
seeing more children, teens. You said that earlier, women, even in their 30s. We're seeing a lot of those numbers. So, 30s doesn't mean, oh, don't think about diabetes. She has that family history of a father with diabetes, and she had gestational hypertension, which is gestational high blood pressure.
Mhm.
Maybe she had gestational diabetes as well. We'd have to ask her a little more questions and look into it, but that's definitely something to consider, that whole big picture as a metabolic issue there. Then also those symptoms she's talking about. Well, those are symptoms of diabetes. Those are symptoms of hyperglycemia. Things like fatigue, increased frequency of urination. We call it polydipsia, which means increased thirst. Polyphagia, meaning increased desire for eat food, increased hunger. Sometimes patients will come into me and they say, "Well, I eat, and then I'm just feeling so lightheaded afterwards, and I feel so tired. I think my blood sugar's dropping. I think I'm hypoglycemic." 98% of the time when someone says that and we check their blood sugar these days, it's not because of a hypoglycemia. It's actually hyperglycemia that they're a little bit sensitive to and they're feeling that. So, the next step when we have somebody coming in with some of these symptoms or risk factors is the easy part. We have a very simple blood test we can do either with a finger stick or a blood draw. We measure something called your hemoglobin A1C. You may see it abbreviated sometimes as HbA1c. This number is on a scale, and if this was not a podcast, I would draw it out for you. You know, on video, you can see me probably using some hand motions for this one too, but it's on a scale. And so for a person with a completely normal, non pre-diabetic, just normal hemoglobin A1C number, their number is going to be below the number 5.7. For someone to be considered pre-diabetic and having some elevated blood sugar levels, their A1C is between the number 5.7 up to the number 6.5. So 5.7 to 6.4. You're in those numbers, you're in the pre-diabetic range. Once you hit that 6.5 number, this is considered diabetic, 6.5 and above. And this level can be drawn without a patient fasting. It's not affected by anything that you ate recently. I tell patients all the time when they're getting it drawn in clinic, they're like, that has to be inaccurate. I ate this morning. I say, I don't care if you had 10 donuts for breakfast or 10 celery sticks. It makes no difference. This is a measurement of your blood sugar that takes into account what your sugar has looked like over the last 3 months. When someone does have diabetes, so let's say we drew their number, we already knew they were diabetic. We use that A1C to measure how well they're doing with their blood sugar over time. We can measure it anywhere from every 3 months to every 6 months or longer. Generally, you can't check it any shorter than 3 months just because of the life of the red blood cell that we're checking. That goes into a little more physiology than we're prepared to go into on the podcast. So just know you can't get it checked any more frequently than 3 months. And we use it to track how well you're doing with your diabetes. If we want to give you a gold star and say you're doing fantastic with controlling your blood sugars, your number is going to be below the number 7.0. So that's a summary: 6.5 and above, that's going to be diabetic. And then 5.7 to that 6.5 number, and between that range, that's going to be in that pre diabetic stage.
Okay. Okay. So makes sense. So your patient, Miss Sally Mae, she gets her blood work done and it shows her hemoglobin A1C is, let's say, 8.
Ouch.
Yeah. So she now fits that diagnosis of type 2 diabetes. Where do we go from here?
So this is the same conversation I have with all of my patients. Even if their A1C is only that pre-diabetic range, we have the same conversation. In fact, I draw it out on a chart with each of these patients on a piece of paper that they take home. I tell them they can either pin this paper up on the refrigerator forever and keep it and be happy about it, or they can burn it. Either way, whatever they feel like they need to do with this paper, but we talk about this every single time. So the first thing we need to address is the 3 ways we can affect the blood sugar. It's going to be diet, exercise, and medication. So for diet, everyone seems to know what the sugars are, right? In their diet. There's things they're supposed to avoid. Things like soda, candy, cake, cookies. But don't forget about things like sweet tea, energy drinks, your Starbucks drink, all of those things right there. They do add up. But everybody seems to understand those pretty clearly. When I say, hey, we got to cut out their sugars, they say, I don't have that many of those. I'm doing a great job. I'm not a sweets person. I'm not eating the donuts. I said, okay, we need to move on because the next step probably for them is going to be those more sneaky sugars.
Yeah.
Those are the carbohydrates. Those are going to be my weakness as well,
Oh,
right,
yeah.
Carrie?
Who doesn't?
Carbohydrates
Come
are
on.
Yeah,
Pasta?
Yes. Oh, that's what I was thinking. Pasta.
I
Pasta
love
is my friend. I could
pasta.
eat pasta
Every
every
day.
day if I could, right? But we can't. We can't do
Yeah.
that. And the reason why is because carbohydrates are broken down in the body into sugars. And so that is the same problem as having the soda, having that cake and the cookies. They're all broken down into sugar. So when we talk about carbs, we're thinking about things like bread, rice, pasta, tortillas, chips, crackers, potatoes. Usually at this point is when my patients' faces start changing and they're like, oh, yeah, that's me. Those are the problems, right? We
Yeah.
all have those weaknesses too.
Right, especially in Texas, if you mention,
Yes.
like, tortilla chips,
Yep.
tortillas,
Yep.
rice and beans,
Yep.
like, you're already made a lot of people mad.
Oh, yeah. I start throwing those out there and they're like, oh,
Yeah.
I forgot
"What?"
about
Yeah.
those. Those are a
It's a
problem.
staple of my diet is what they're
Yes,
saying.
it
Yeah.
is. It really is. And so that's what we have to focus on. So these all have to be limited. And depending on the severity of diabetes, some of them have to be eliminated completely. I'm not saying every single person can never, ever have, a tortilla again, but we have to talk about reducing the consumption, reducing how often we have them. If you have very uncontrolled diabetes, yeah, you may not get to have a normal tortilla again, but you might be able to have those mission low carb tortillas sometimes. We can make some ways to work around these things. And that's when a dietitian can be very helpful as well. But even in the dietitian world, there has been some misconceptions about what you're allowed to eat and not allowed to eat. And so that's one of the things I want to definitely address because patients will come back to me. Maybe they see someone, or maybe they just got some advice from a friend that tells them things like, you can't have fruit. Let's say this super loud. You can have fruit as a diabetic. Some of our type 1 diabetics, who we call them brittle diabetics, who
Mhm.
have very uncontrolled blood sugars, are on insulin in high amounts, especially those like kiddos and stuff with type 1 diabetes, they may not be able to have fruits or certain kinds of fruits or have to be very careful with them. The majority of my type 2 diabetics, especially as adults, you can have fruit. Most fruits will not have a large swing in your glucose. And honestly, I would much, much prefer you to have a handful of grapes than that bag of chips that's been sitting in your desk all day when you've been
Sure.
feeling snacky. Because
Yeah.
that's what ends up happening is we bash everybody's hand and say, no fruit, fruits are bad. Well, then you know what? As a patient, you get really tired of still being told things are bad and you can't have them. And then when you get snacky, you're sitting in your office or you're sitting around the house and you're just looking around and you don't have anything on hand. And you know what? You decide, well, I can't have the fruit. I'm just going to go ahead and give up anyways. And I'm going to have that bag of chips.
Right.
You can also have all the veggies. Go for the veggies. You can have any of those that you want. For meat, though, you do want to focus on that. Yes, you can have meat, but we need to avoid things like the breaded and the fried meats that have all that breading. That's carbohydrates added in right there. You don't need that.
Yeah.
Focus on lean meats such as turkey and fish. For your cardiovascular health, I know our cardiologists want us to throw these things out there. Limiting your red meat in general is good. Limiting to 3 times or less
Yeah.
per week is good. I know
Good for your
Carrie.
colon
Yeah,
too,
I was about to
right?
say there's going to be some colon health in that
Yeah.
one too.
Absolutely. It was you're talking about the fruit that always gets me because it's like, oh, so now all of our fiber's gone too,
Right.
right?
Yes. A good point. Good point. Yes. And so that is one of those things. People a lot of times will come in with a lot of GI complaints, I feel like, when they
Yeah.
are diabetic or pre-diabetic. And then when we break it down, it has a lot to do with the diet, right?
Absolutely. And a lot of it too is adding in, which we now have a lot of data on, that it's its own problem, is a lot of the sugar substitutes, right? That are
Yes.
geared and advertised and marketed to diabetics
Hmm.
that have sugar substitutes. And I'm here to tell you, there's a lot of GI side effects with those as well, a lot of them. And so that also just makes people not feel well. And then they end up just doing a lot of that, which is really, as we're coming to realize, not good for you either.
Right. And so that's when people will talk about, okay, they're drinking a lot of Dr. Peppers, like their favorite drink. They're doing 4 a day. I'm like, okay, we've got to cut that back.
Mhm.
So they ask, can I do a diet Dr. Pepper? And I say, sure. You can switch those to diet Dr. Peppers for now, but our goal is not to have 4 diet Dr.
Yeah.
Peppers a day
Yeah,
either, right?
exactly.
Long term, we've got to get those down as well. So let's pull back the diet Dr. Peppers because, as we've talked about in previous episodes, those artificial sugars are going to cause more IBS symptoms. What else were you saying before?
Well, I mean, there's even studies about they're concerned about the risk of younger cancers being because of a lot of these things
Right.
as well. So, not just even just the IBS, but potentially some increased cancer risk based on some, studies that are being done.
Right. And so there's more and more data coming out. So truly, if we're going to cut back, we need to cut back and go to the OG, the original, right? We need to
Yeah.
go to some water. And a lot of times if we're trying to cut out the soda, practical tips for that cutting out that soda is yes, you can do something carbonated. Some people just need that fizzy carbonation type of
Sure.
feeling. Go for a no sugar carbonated water. That's fine. Sometimes they just have the carbonation in there without the artificial sugars itself to
Mhm.
make it sweet. And that's even a little bit better. But also ditch the side of French fries, opt for a veggie or fruit. Yes, that fruit's okay. Eat everything with a burger except for the burger bun. You can still have the things you love and enjoy, just
Mhm.
change them up. You want to make your quesadillas or your fajitas or your um, Oh, what's the one? Enchiladas.
Mhm.
Use a low carb tortilla. No, they do not taste as good as the homemade ones. No, they do not taste as good as like the HEB ones that they
Right.
make. They're not as good, but you can make them better. You opt to utilize more spices.
Mhm.
All the spices we use, they're not going to affect your diabetes unless they have some sugar thrown in there. But using some things with a lot of flavor can help
Mhm.
overcome maybe my bland tortilla.
Right.
There's some ways around this. And it's not just deciding to get a salad one time, it's all about
Mhm.
consistency.
Sure. And balance, yeah.
Yes, that balance, that consistency. So that whole thing was just all about the diet change. But that's number one. That's why we always start with that discussion. Number two is going to be exercise. A sedentary lifestyle, which is just kind of being a couch potato, is a huge risk factor for pre-diabetes and for type 2 diabetes. The skeletal muscles, which are those the ones that we use to make, a muscle in your arms, your legs, all that good stuff, those in the body can actually break down sugar when they're exercising. The recommendation is 150 minutes per week of aerobic exercise, 150. This means getting the heart rate up and sustained. This means trying to break a sweat. One of the things I always talk about with my patients, I ask them how much exercise they're getting, and they always say, well, I go for walks. I walk my dog. So, quick story here. Carrie, I think you'll appreciate this because you have a cute little dog too.
Mhm.
So they always say that I walk my dog and that's my exercise. I try to walk him every night. Well, I've learned from past experience now to ask somebody what kind of dog they have.
Yeah.
Because if they have a sweet little dog that's Carrie's dog size, that's Sergeant size, what
Yeah.
kind of dog is he again?
Boston Terrier.
Okay,
Yeah.
Boston Terrier size,
Tiny.
or this one that my patient was talking about was her like Chihuahua size, and they walk the dog. They take a lot of stops. The dog has to go pee pee
Yeah.
on the way. They don't go that far. They come back. It may take them an hour, but I realized that patient is not getting their heart rate elevated up, sustained. They are not breaking
Yeah.
a sweat
Not
unless it's
unless
100
not unless the
degrees.
dog got off the leash and you're chasing
Yeah,
him.
if the, you're
That's
if the,
about the only
exactly,
time.
if you're chasing that dog down the street, then
Yeah,
every
maybe.
time,
Maybe.
then maybe that also sounds like a problem.
Yeah.
But that is one of the things we've got to talk about is that walking the dog does not count. Maybe if you have a big German Shepherd dog and he and you are running together, not walking, or maybe
Mhm.
doing a jog, that counts. We've got to find something creative. And there's a lot of different exercises you can do. Carrie and I enjoy exercises in completely different ways. She's a tennis girl. I just texted the tennis pro the other day asking if I could try to learn how to play tennis because I really want to get in on this whole tennis game,
Yeah.
Carrie.
Come on.
I feel like this is a trend and everybody else is
I'm
playing tennis. I want to
yeah.
learn. But,
I'm still not any good, but you're more than welcome to come.
I think that's great. And that's a great example. You may not be very good at
Mhm.
a sport or an exercise, but you're doing it. And do you get an exercise out of it, even if you're not very good?
Absolutely, 100%.
I just started
Probably more of an exercise if you're not very good.
right. I used to be all cardio girl and I was only doing spin. And now I've been learning about the benefits of strength training. And I've
Yeah.
been doing that for the last 3 months, which has been a whole new world. So there's a lot of differences in things that you can do. So that's the second part of exercise. So for medications, there are a lot of medications that we can do. There's a lot of options. But no matter what medication is used, you have to focus on the diet and exercise changes that are necessary. And there's no way around that fact. I was driving over here actually, and I was listening to an ad on the radio that was talking about getting a prescription for GLP-1s through, some online
Mhm.
website or something. It's like, it'll change your life. And they had some man talking on there about how he didn't have to change his lifestyle at all. And he lost 20 pounds and blah, blah, blah. And all I could think is, that's exactly the problem.
Right.
You need to change your lifestyle.
Yeah.
And the fact you lost 20 pounds, great. When you come off that medication, you are going to gain every single one of those pounds back, maybe
Absolutely.
even more. And you're not fixing the same problem. If you're still ingesting all of those foods you shouldn't be, you're not helping your liver. You're not helping your heart. All the other benefits, just because you lost the weight doesn't mean you did it in a healthy
Yeah.
way.
You're an unhealthy skinnier.
Yes, you're skinny fat
Yeah,
now. It's a
skinny
bigger
fat now.
problem.
Yeah, exactly. Right. So, okay. All right. Well, so back to Miss Sally Mae. Now that we've gone over all of that, her A1C of 8. Okay. So you're wanting to start medication. What do you decide? How do you decide?
Yeah, A1C and 8, we probably need to start some medication for you. We could do an entire episode solely on type 2 diabetic
Right.
medication, so I won't focus on this one extensively, but we do have several options. The most common medication we use is called metformin. It's an
Mhm.
oral pill. It's inexpensive. It's relatively well tolerated. You could have some GI upset
Mhm.
side effects. I know Carrie probably hears about this quite often,
Oh,
or
yes.
people come in to see her and she's like, that could be your metformin.
Yeah. Usually my first suggestion is, "Are you on extended release?" Just as an
Yes,
aside,
yes.
but yeah.
Yeah, so metformin comes in different
Yep.
formulations, and an extended release generally has
Mhm.
more tolerable side effects. So if you're having GI upset with it, you can talk about the different formulation. It's been around forever, though. It's very safe. Contrary to some fun new news things that we heard this last couple years, they're like, "Oh, metformin's going to kill your kidneys." No, you know what kills your kidneys?
Diabetes.
Diabetes kills your
Yeah.
kidneys.
Yeah.
So metformin's not going to hurt your kidneys unless your kidneys are already severely damaged from probably your diabetes. So it's relatively well tolerated. Again, been around forever. It also does not lower your blood sugar too much, causing hypoglycemia like insulin does, or some of the older generation diabetic medications. So, we don't have to worry about you quickly needing to, carry something like glucagon with you,
Mhm.
or trying to take a snack with you, or just worrying you're going to pass out somewhere because of a low glucose. We actually even use metformin for people who don't have any issues with blood sugar for completely different reasons, like PCOS.
Right.
But for patients with other conditions, in addition to high blood sugar, we might consider medications in that GLP-1 or SGLT2 class. GLP-1s have been in the news, obviously, nonstop. I just heard it on the radio, like we said, for weight loss. But we've been using them for years. Like I've been
Mhm.
using them for at least 6 years to treat diabetes, type 2 diabetes, with the benefit that they are cardioprotective, especially for people with heart disease. So if you are a diabetic that also has cardiovascular issues, let's talk about things like you've had a history of a heart attack, you have a plaque buildup in your coronary arteries, you have issues with blood flow in the legs. There's a lot of other different things. You're at risk for stroke. We can use this medicine to decrease some of those risks. The SGLT2 meds are wonderful for those who have kidney disease.
Mhm.
Research is actually rapidly advancing around these two classes of medicines to find more benefits for their use. Yes, weight loss is there, but there's actually benefits for things like the heart and the kidneys for people who aren't even diabetic as well, because they also don't cause low blood sugar. So there's some really awesome things. If you can't tolerate metformin, these would be the next steps that we usually are
Mhm.
starting with. There are additional medications down the list, some of our older drugs that are not being as used as much anymore. Of course, there's insulin still
Right.
that we can use for type 2 diabetics to get them controlled. But all this is based on a patient's history, contraindications, what side effects they've had, maybe what their GI doctor says they might need as well, or their
Yeah.
cardiologist. So it's a multidisciplinary approach.
Absolutely, as diabetes has now become. So it
Yes.
sounds like our patient, Miss Sally Mae, is off to a good start with getting her type 2 diabetes under control. And we know the risk factors and the diet and exercise changes needed to help if someone is pre diabetic. The prevalence of type 2 diabetes has risen alarmingly in the past decade, in large part linked to the trend in obesity and a more sedentary lifestyle. So, this is your sign to start making those changes now. Talk to your doctor if you are concerned you might be at risk for prediabetes.
Absolutely. I think it's so important that we have these conversations.
100%. All right. It is now sports hype time, which
Woo!
again in the fall is my favorite.
I do love football
Yes,
season. This
me
is so
too. Me
fun.
too. This is the place where medicine and sports meet. I'm not sure if everyone watched it who's listening to this. I know a lot of people did, but this season, quarterback for the Miami Dolphins, who I am not going to try to butcher his name, but Tua, I think everyone knows who that
Tua,
is.
yeah.
Yeah, was part of a really dramatic collision on the field with Bills safety DeMar Hamlin, which interestingly enough, we've also discussed on this podcast.
Poor
So
guy.
both players, yeah, exactly, poor guys, which led to another concussion. That made at least 3 concussions in the last 24 months for Tua. This again brought up the use of guardian caps this season in the NFL, as it's been worn by some players already this season. So you may have already seen it. The topic was recently covered even in mainstream media. So People Magazine was talking about it, and then some content creators, such as neurosurgeon Dr. Betsy Grunch, who TikTok handle is Lady Spine Doc. If you want to check her out for more information, all things neurosurgery. So Jessica, let's start with some basics. What is a concussion?
So, this is actually one of the fun things we get to talk about, because I get to deal with this a lot as being a team physician for a collegiate basketball team. I had never realized how much we would be talking about this,
Yeah.
especially in the primary care setting. And it is something in the news that we talk about as well. But let's put some of this into some more basic terms. We don't have to go into all the
Yeah.
pathophysiology just for the sports hype segment.
Nah.
I told Carrie the other day I gave a huge lecture on this for about an hour
Right.
just on
Yeah.
concussions and CTE.
We're
We'll skip that.
we're just giving the highlights, a
Yeah,
highlight reel,
the
as they
fun
would
parts,
say.
right? Yeah.
Yes.
So a concussion is when a head impact occurs forcefully enough that the force is spread throughout the brain and causes it to, let's say, jostle within the skull. It's like thumping the outside of an eggshell and having the little liquid yolk inside jiggle around. Not good for our little brains. They're swimming in there and they want to be protected and they don't like the jostling. It doesn't have to be a direct impact to the head, though, let's remember.
Yep.
It can also be a swivel of the neck. We can hit the floor. It doesn't have to be the classic football type injury. Lots of different sports can have this happen in a lot of different ways. And then there's
Mhm.
people without actually sports injuries that have this happen as well. It's not just car accidents or, football tackles.
Absolutely. I think it's a great way to describe it. So now what is this Guardian cap that I just mentioned that has been in the news?
So this has been in the news lately, and there's a lot of
A lot
controversy
of
around it.
controversy. Yep.
Yeah, so it's one of those things, and it's not one of those things that we see used all the time, especially in like the collegiate athletes, obviously, but it
Mhm.
is something they're talking about for the NFL. But it's a soft shell accessory that can be worn over a player's helmet, designed to reduce the number of concussions. That is the theory. According to the founder of Guardian Sports, when players wore the foam covering, it reduced the number of concussions by 50%. That's a huge outcome if that is the case.
Right.
This is because theoretically the cap is leads to a 10 to 20% reduction in the forces generated with a collision. Interestingly, it does all of that and only weighs 7 ounces. I mean, that's like nothing, right?
Yeah.
It's like wrapping the eggs that we're talking about, that little protective egg of your head,
Mhm.
in a foam during transport to limit the jiggling of egg yolk with road bumps, like if you're driving and you're just kind of protecting it there.
Yeah, a little egg crate.
Yeah.
I like that. And just, as of note, it was actually invented a while ago back in 2010, but wasn't really introduced to any training camps until 2022. And then in the kind of 2023 and 2024 seasons in the NFL, it actually became required in training camps for most positions. And then they actually this year cleared it for use in the regular season. Now, in general, Jess, why do we care? Why do we want to reduce concussions? Why does it matter?
Well, besides the fact that a concussion itself has been associated with prolonged symptoms such as headaches, nausea, dizziness, difficulty concentrating, sensitivity to light and sound, that post concussion syndrome that can last from anywhere from days to weeks to months, actually. There is also research showing potential long term negative effects from repeated traumatic brain injuries. And don't get me wrong, you need to know this, that concussions are mild traumatic brain injuries.
Mhm.
But there's a disorder that's made the news quite often right now called chronic traumatic encephalopathy. A lot of people say CTE. That has been in the news a lot lately. I mean, one of the Kelsey brothers was just talking about it, saying that he swears he must have it. Unfortunately, we won't know.
Right.
The only way to diagnose this, sadly, is right now is just after death during an autopsy of the brain when we look at it underneath a microscope.
Mhm.
There's a lot of research going on right now regarding potential special MRIs that can be used to evaluate the brain, but these are not your standard MRI that every hospital system has, and those are still in the research phase, and there's just no cure for CTE. But back to what it is. In basic terms, CTE is when repeated head injuries lead to the death of nerve cells. Let's just say that in the brain. CTE can cause many problems such as cognitive issues, memory loss, behavioral problems, including impulsive behavior and aggression. It has also been linked to depression and suicidal thoughts.
Yeah, that's really sad. And a lot of these really develop years, sometimes even decades after trauma with some of those symptoms that you mentioned. Some of the mental health behavior can be a little earlier, and with some of the other things being later in life. But like you said, depression, anxiety, and suicidal ideation is really a big concern for some of these players and some of the other exposures you mentioned that have this repeatedly. And I know you said something about this earlier, but it's not just in NFL players.
No, we've seen it in hockey players, boxers, military personnel exposed to explosive blasts, just to name a few. They actually have a whole different term for it when it's talking about boxers. That's one of the
Hmm.
places we've seen that a lot of research has been done on boxers' brains post-mortem, seeing a lot of those character changes, those personality changes. And the reason why it makes a big difference is, do we let our kids play football? Do
Right.
we, at the collegiate level, we've got athletes that ask, "Hey, I've had several concussions. How many more concussions can I have before I'm going to have long-term effects?" We're talking about 18, 19, 20, 22-year-old young athletes. Well, they have our whole lives ahead of them. They
Yeah.
don't want to risk it all. They don't want to risk that, depression, anxiety, memory issues, having dementia like symptoms, in their 30s just for a couple years of some fun athletics that should be a fun thing, not just for our viewing pleasure as the people that are rooting
Absolutely.
for them on the
For
weekends.
sure. And I think overall the question is does the Guardian cap do what it claims? Which again, as we've said, I've learned is a polarizing topic.
Absolutely. That's the thing we don't know. We've got to try to figure it out. Um, it's one that many neurosurgeons have weighed in on. To date, we have seen 4 studies published on the Guardian cap, which is not a lot of
No.
data to go on. The data the NFL cites has not been released to the public, so it makes it even more difficult to assess the benefit of its use. The summary consensus of these studies that are available is that so far we have 0 studies that show a reduction in the amount of concussions during a game. It may help lessen the impact of a soft hit, but sadly, most concussions occur because of such a forceful blow. The unprotected neck still moves around, causing that whiplash effect. Like we said, you don't actually
Mhm.
have to hit your head to have a concussion. You just have to jostle that brain in some way.
Yeah, I think I saw one of the neurosurgeons they interviewed. What he said basically is, yeah, it'll work great if you have a steel neck. Basically,
Yeah,
like if you have a rod in your neck that's not going to allow whiplash, but unfortunately, a lot of these really forceful blows, the direct impact protection may not be enough, is the problem to prevent a concussion.
absolutely.
But I think overall, it's a step in the right direction to try to protect players, all the way down from youth football to professionals. Like you said, we're looking at our own kids and, if they want to do this for fun or for a living, how we can protect them. But we really just need more data, more studies to see what's going to actually decrease the risk of concussions, their short and their long-term ramifications.
Absolutely. And I think that's one of the things. Let's just keep the conversation going about this stuff.
Yeah, it's a like I said, step in the right direction. All right, what a great episode. We have covered a lot about diabetes today.
Absolutely. And we've beefed up everyone's medical sports knowledge for the day. Since suicidal thoughts were mentioned in today's episode, we want to remind listeners if you have thoughts of hurting yourself, call 911 or your local emergency number or contact the suicide hotline. In the United States, call the number 988 to reach the 988 Suicide and Crisis Lifeline. They are
Great.
there to help.
Great reminder. And don't forget, if you are a listener claiming CME credit, please look in the show notes for instructions.
And for all of our listeners, thank you for tuning in. Please like, subscribe, and share the episode. Let us know what other topics you're interested in through our Instagram and stay tuned for the next episode.